what are the main eating disorders that you treat? And could you give some classification of the different disorders?
Okay, I'll do my best. Well, the one most people will have heard of, which I mentioned already, is anorexia nervosa, which is a restrictive eating disorder where, for a variety of different reasons, there's an inadequate intake of nutrition. Why somebody might be doing that, again, is multifaceted. But towards the surface, at least, there can be fears of weight gain, a desire for thinness, body dysmorphia, meaning their perception of themselves doesn't match the reality of what they actually look like. So somebody who is underweight might look at themselves in the mirror in a photograph and think that they're fat. And there are two types of anorexia. There's a restricting type, which I described just now, and purging type. So they might be restricting and purging. And we would also classify, for example, excessive exercising as a form of purging. Because it's with the intention to lose weight, to affect their body shape and size.
Okay. And then the other major disorders, I guess, bulimia is the next
Bulimia nervosa, which is characterized by using some means to expel consumed food from the body. So very typically that would be by making yourself vomit. But it also could be through the use of laxatives, say, and after eating, just in one of those two primary ways, expelling what's been eaten from the body before it can be digested.
Okay. And then is the third major type binging of eating disorder?
Typically we would say so, binge eating disorder, which is eating in excess of the body's need for nutrition. But actually, statistically, worldwide, there's a classification which covers a multitude of eating disorders that don't meet the criteria for anorexia diagnosis or bulimia diagnosis, and it's eating disorder not specified. And even though in treatment where I work, that's not the most common one to show up, according to international research, it's the most common eating disorder. So, and then there's another one, ARFID, which is where it's more a sensory kind of issue, and that can be quite common with people who are neurodivergent, for example.
Okay.
And not typically about concerns to manipulate the body weight or appearance, but it's more intense challenges around how food tastes, feels in the mouth, smells, all the sensory kind of issues.
Okay, so we have these major classifications. I guess the major ones are anorexia nervosa, bulimia nervosa, and binge eating. Which styles, or what do you normally treat at your facility? What would you see most commonly?
Most commonly anorexia. Yeah, most commonly anorexia. As I say, because medical criteria is a significant component in why people might need that level of care. They have to be assessed to need such a high level of care, and being underweight, insufficient nutrition intake are going to cause medical problems. So most commonly, but we also do have people with bulimia, binge eating disorder. I think we have people with all of the diagnosis, but predominantly anorexia.
Okay. Because anorexia is the most dangerous. Is that the reason why people are getting residential treatment for anorexia at your facility?
Yeah, anorexia has the second highest death rate next to opioid abuse.
Wow. Across the board, like with male and female, young people, old people?
Yeah. So death doesn't necessarily come from starvation, though it does. It can come from other medical issues that arise from being malnourished. Being malnourished can cause all kinds of heart problems. So people can have heart attacks, but suicide is also a big percentage of that death rate.
At the facility you're working in, what would a regular day's treatment look like for those patients?
A typical day is going to start by doing vitals first thing. So that would be blood pressure, things like that. And we have a nurse 24/7 in the facility, so they do that. Then they would have their first meal of the day, and so when they're sitting at the table, they would have we call a food and feelings sheet, where they have different spaces where they can know what they're doing, how they're feeling, noting any eating disorder thoughts, noting any healthy thoughts, recovery-minded thoughts as they're going through the process of eating. And they with usually 2 members of staff.
Each patient, or as a group?
No, at the table. At the table,
Okay.
There would be a minimum of 1, but often 2 members of staff. And very typically, they play table games as a way of kind of distracting, having something else, also to overcome for many people with eating disorders, there's embarrassment about eating in front of other people. Eating disorders tend to lead to isolating behavior, particularly at times of eating. So there can be a lot of sort of anxiety just being at the table eating in front of other people. So playing these kinds of table games, which are, it's a while since I've done table work, so I can't think of them, but just mental games to help them be distracted, to be engaged with each other. And before the meal starts, they would do a check-in to help them tune into their hunger cues. And that's done on a scale of 1 to 10. And then at the end of the meal, there's
what are hunger cues? Can you elaborate on that?
Yeah, so it's assessing your level of hunger. Typically at breakfast, say, it's first meal of the day, no one's eaten, or most people haven't eaten since the previous evening. So hunger might be typically at a 3 or 4, something like that. And then at the end of the meal, they do a checkout, which is, again, giving them an opportunity to attune to their fullness cues. And a healthy fullness checkout would be something like a 7, maybe an 8. 9, 10, then you've probably eaten past what the natural fullness cue would have been. So again, depending on the eating disorder, there's difficulty identifying what those hunger cues are. And so every day at every meal, there's an opportunity to have to intentionally try and attune to those messages.
You and I, we both come from this mindfulness tradition, and something I was reading today that, eating disorder is very much connected to a sort of a dysfunctional sense of embodiment. So I don't know if you would agree with that, but I would guess that looking at these hunger cues and would start to reconnect someone and give them more of a sense of their embodied state in relation to eating.
Exactly. Yeah. There's a real disconnection for most people with eating disorders from the body, from bodily awareness, from interoception capacity to look inwards and notice and identify what's happening internally within the body system. So yeah, it's a way of inviting them to practice those skills, and so people say with anorexia, even though it's breakfast, they haven't eaten since the evening before, they might check in at a 10 because they think they don't need to eat and they can't perceive really what's going on in their body. They might perceive an emotional fullness, say, or even a numbness that doesn't allow them to identify what's actually going on. So they go with what they think. So I think I'm full. I think I don't need to eat. Therefore, I'm checking in at a 10 or a 9.
Okay.
Whereas in reality, that they're just disconnected from bodies, as you say.
Okay. And the goal at that first meal, is it to eat a certain amount of food? Like if somebody is refusing to eat or they're not eating, how do you progress that? Like what is the intention with every time you sit down to eat with the client?
Well, each patient has an individual meal plan which they work together with our dietitian once a week to sit down and plan for the week. And obviously the dietitian doesn't let them dictate, but it's to allow them some contribution to understanding why their meal plan is what it is. And they have a certain amount of changes they can make that's limited to how many they can make a week. And so how much is on their plate is going to be dictated by their meal plan, and that may be different for different people. Depending on where they are in their process of recovery, it might be that they have to eat everything, right? And there's a certain number of calories in each meal to make an amount for the day that they have to reach to hit their nutritional goals. And if they are unable or unwilling to eat the food, then they would be offered a liquid supplement.
Okay.
And they can decline that, there's no use of force in any of this. But certain things, so typically after breakfast, for example, they would go on a short beach walk. We're very near the ocean. And so they would have a mindful beach walk, but they can't go on that walk after breakfast if they've not been meal compliant, say the day before.
Okay.
And then on Thursdays and Saturdays, there are outings where they might go to a beach for a number of hours, or they might go to somewhere else in nature. And they need to be compliant for a certain number of days over the previous week to be able to go on those outings.
Do the patients at your facility, are they there voluntarily, or they're put there, or is it because their families are placing them there, or what? Because I find in my work that if someone doesn't want to be in a place, it's very difficult to help them. But also that can also be part of the person's process that, maybe they go to a residential facility, they don't want to be there, but that can be part of a longer process of them eventually being willing to be there and to engage more deeply in the process. But certainly if somebody comes to a facility and they don't want to be there, that can be more challenging to work with.
Right. So it's voluntary, except in the case of minors, right? So under 18. And very often they are the ones who don't want to be there, in part because, it's kind of weird as an adolescent to be away from home, living with a bunch of other women who you don't know. And all these things that level of care requires. But also, they might be very attached to their eating disorder, and unwilling to give it up because it's serving a purpose for them, which I'm sure we'll come on to talk about. So it tends to be more the minors, the adolescents who are entrenched in that resistance to being in treatment, and sometimes they don't get past that, and we have people returning because they weren't ready, they weren't developmentally ready sometimes too, psychologically. And they need a little more maturity, a little brain development to be able to actually fully engage and understand the challenge that their eating disorder brings for them, and find the desire to want to.
And okay, so to continue with the schedule, how many meals will they have a day?
They'll have 3 meals a day, and typically 2 snacks. So one snack would be at 3 p.m. in the afternoon. The other one would be in the evening. I think it's around 8 o'clock. There are a few people who might also have a morning snack, and they typically might be people who are trying to weight restore and it's not happening for whatever reason. Or it might be that they want to challenge themselves, right? They are really invested in recovery, and they voluntarily asked to do that additional snack.
What is the therapy schedule, and what types of therapy will they have?
Well, every patient has an individual therapist who they see 3 times a week.
Okay.
And they meet the dietitian, as I say, 1 time a week, and they have an intake assessment by a psychiatrist when they first come in. And then there are groups throughout the day. So typically after the beach walk, there'll be a group at 9:30. There'll be another group at 11. Then 12, they have lunch. They have some tech time where they get their phones and so on. After lunch for 30 minutes to an hour, depending on the schedule for the day. And then there'll be a group, say, at 2, another group at 4 after the afternoon snack. And then in the evening, it's more, for some, it's shower times and stuff. They might watch a movie together. It sort of slows down.
That's pretty intense as the therapy program. I've talked to people who've done residential programs, mostly in rehab, but some of them will not get any individual therapy, or will maybe get 1 individual therapy session, very limited. So it sounds like the treatment that you're given is pretty intense for the client, for the patient.
Yeah, the groups vary a lot though, so they're not all kind of group therapy type things. For example, we have somebody who comes in and does ukulele with them, and they do music, and there might be a horticulture group where they go outside in the garden and they're growing things, and there's an art therapy group. So there's quite a variety of different ways of engaging them as a whole person, not just, you've got an eating disorder, you're sick, and everything's focused on that. It's a more holistic approach to, the whole person rather than just their disorder.
What about embodiment practices like yoga or qigong or tai chi? Are these part of your program?
Yeah, they have a yoga group once a week, and I do an embodiment, which I just recently started. So yeah, twice a week they're doing body-based, non-cognitive kind of work.